ATLS. Advanced Trauma Life Support. What is trauma? Physical injury caused by an external source. The biggest killer in Pakistan? Trauma. Death following injuries. Trimodal distribution. Immediate within minutes, 50%, on road, due to widespread damage to brain, ruptured heart or great vessels, only preventive measures. Within hours, golden hours, minus 30%, life-threatening injuries like facial injuries leading to airways obstruction, altered breathing mechanism, massive blood loss. Within days, 20%. Sepsis and multi-organ failure. Deaths following injuries. Trimodal distribution. Dangerous injuries. Crash greater than 20 miles per hour. Fall from height of 20 feet or more. Death of another person. Ejection of patient. The history of the ATLS. In February 1976, a tragedy occurred that would change the first hour of trauma care for patients. Dr. Jim Steiner, an orthopedic surgeon, crashed his small plane into a cornfield in rural Nebraska. Dr. Steiner sustained serious injuries, 3 of his children sustained critical injuries, and 1 child sustained minor injuries. His wife was killed instantly. Continue. The care that he and his family received was less than adequate. There was an obvious lack of training for proper triage and injury treatment. The surgeon, recognizing how inadequate his treatment was, stated, "When I can provide better care in the field with limited resources than what my children and I received at the primary care facility, there is something wrong with the system and the system has to be changed." Concept of ATLS. He started the course in Nebraska in 1978, which was taken up by American College of Surgeons and given nationally 1979. Advanced Trauma Life Support, ATLS, is a training program for doctors. Its goal is to teach a simplified and standardized approach for trauma patients. The philosophy of the ATLS program is to treat the greatest threat to life first and then reassess and treat again. The ATLS basic concepts. Treat the greatest threat to life first using the ABD approach. Don't start with history. Full diagnosis is not needed to treat a life-threatening emergency. Lack of a definitive diagnosis should not impede the application of indicated treatment. Initial assessment. Rapid primary survey, 60 seconds exam. Resuscitation. Secondary survey. Initiate definitive care. It is a continuous process. Primary survey. Quick head-to-toe examination. The first and key part of the assessment of patients presenting with trauma is called the primary survey. During this time, life-threatening injuries are identified and simultaneously resuscitation is begun. Primary survey. The ABCs. A. Airway with cervical spine control. B. Breathing and ventilation. C. Circulation with hemorrhage control. D. Disability, neurologic status. E. Exposure, prevent hypothermia. Airway with cervical spine control. Establish patent airway. Cervical spine control. Assume cervical spine injury. Blunt injury above clavicle. Multisystem trauma. Altered level of consciousness. Airway problems are a common cause of preventable deaths. Failure to recognize airway need. Inability to establish airway. Failure to correct an incorrectly placed airway. Dislodgement of a correctly placed airway. Delay in establishing adequate ventilation. Aspiration of gastric contents. Objective signs of airway obstruction. Look if agitated, agitation, hypoxia. Using accessory muscles or not. Listen for abnormal sounds. Noisy breathing is obstructed breathing. Feel the trachea. Management. A rigid suction device is essential. All trauma victims need supplemental O2. Airway maintenance. Chin lift. Modified jaw thrust. Oral, nasopharyngeal airway. Surgical, needle cricothyreoidotomy. Breathing and ventilation. The chest must be examined by inspection, palpation, percussion and auscultation. Subcutaneous emphysema and tracheal deviation must be identified if present. Indication for ventilation in chest injury. Tachypnea above 40. Extensive pulmonary contusion or diffuse infiltrative change on X-ray. Life-threatening chest injuries which may impair ventilation. Airway obstruction. Open pneumothorax. Tension pneumothorax. Massive hemitrax 1,500 milliliters. Flail chest with pulmonary contusion. Cardiac tamponade. C. Circulation with hemorrhage control. Hemorrhage is the predominant cause of preventable post-injury deaths. Hypovolemic shock is caused by significant blood loss. 2 large-bore intravenous lines are established and crystalloid solution given. If the patient does not respond to this, type-specific blood, or O-negative should be given. C. Circulation. Radial pulse is palpable with BP of 80 mm of Hg. Femoral pulse is palpable with BP of 70 mm of Hg. Carotid pulse is palpable with BP of 60 mm of Hg. Regions from where patient can lose large volume of blood. Externally. The chest. The abdomen. The retroperitoneum. Into muscle compartment. Circulation. Assess. Blood volume loss and cardiac output. Level of consciousness. Skin color and temperature. Pulse. Don't wait for BP drop to make a diagnosis of hypovolemic shock. At least 30% volume loss is needed for BP to drop. Causes of shock in trauma. Hemorrhage, the commonest cause of hypovolemic shock in trauma patients. Non-hemorrhagic. Cardiac pump problems. Cardiac tamponade. Tension pneumothorax. Myocardial contusion. Neurogenic shock. Hypovolemia resulting from internal loss. Intra-abdominal or intrathoracic injury. Fractures of the pelvis and/or femur. Penetrating injuries with arterial or venous involvement. Disability. Rapid neurological evaluation. Level of consciousness. Alert. V responds to voice. P responds to pain. U unresponsive. Pupils. Glasgow Coma Scale or GCS is a neurological scale that aims to give a reliable objective way of recording the conscious state of a person for initial as well as subsequent assessment. Continued. The scale comprises 3 tests, I, verbal and motor responses. The 3 values separately as well as their sum are considered. The lowest possible GCS, the sum, is 3, deep coma or death, while the highest is 15, fully awake person. Exposure, environment. Undress patient completely. Do not forget the back of the patient. Protect from hypothermia. Intravenous fluids should be warmed and a warm environment maintained. Patient privacy should be maintained. Resuscitation phase. Secure large bore for access. Shock therapy. Continuous ECG monitoring. Blood samples, CBC, ABGs, cross-match, glucose, coagulation studies. NG and Foley's catheter, if not contraindicated. Monitoring. Vital signs, temp, pulse, respiration and BP. Urinary output. ECG. Pulse oximetry, ABGs. Priority X-rays. Chest, AP. Pelvis, AP. Secondary survey. Initiate resuscitation and reassess ABCs before secondary survey. Head-to-toe evaluation. Complete neurological exam. X-rays as indicated. Special procedures E.GDPL etc. Tubes and fingers in every orifice. Re-evaluation. Continue monitoring. New findings, deterioration, improvement. High index of suspicion for unapparent injuries. Pain relief after surgical consultation. Secondary survey. Mechanism of injury. Blunt direction of impact determines injury pattern. History and description of events is important. Penetrating energy transfer factors like velocity and caliber of bullet, trajectory and distance. Head and face. Head pupils visual acuity injury. Maxillofacial assume C-spine injury. Spine and neck. Maintain immobilization of neck until injury excluded. Absence of neurological deficit does not exclude neck injury. Penetrating neck injury if going through platysma requires evaluation. Chest and abdomen. Sequentially assessed for potential threats to life. Extremities and back. Long bone hash. Neurovascular injuries. Compound hash. Adjuncts to secondary survey. Radiology, plane and contrast. USG. CT. Endoscopies, broncho, esophago. Angiography. Record keeping. Meticulous record keeping is essential to evaluate patients' needs and clinical status, especially since more than one doctor often caring for patient. Accurate record of fluids given flow sheet. Medical legal problems arise frequently and precise records are helpful for all concerned. Definitive care. Treatment by appropriate consultant. Prevention of trauma. Primary prevention: anti-drinking driving, speed limit. Secondary: active helmet, seat belts, passive ABS, airbags. Tertiary: minimize the effects of injury by improving health care delivery. Question 1. A patient is involved in a motor vehicle accident and suffers multi-organ trauma. In emergency room, he is found hypotensive, tachycardiac, and his abdomen is distended. He is disoriented and confused. He has GCS of 9, his pulses are thready. What is most likely cause of shock? A. Closed head injury. B. Intra-abdominal hemorrhage. C. Pneumothorax. D. Septic shock. Question 2. Which of following leads to dangerous injuries? A. Crash at speed 20 miles, hour. B. Fall from height of 20 feet or more. C. Ejection of patient from vehicle. D. All of above.